Good morning, everyone. I'm very, very pleased to be invited to the first conference of Bladder Health UK. And we had lots of help from Bladder Health UK in setting up and delivering this important trial, which I'm going to spend about 20 minutes taking you through. So I led the trial, but all of these brilliant people contributed to it, and we ended up with level 1 evidence to support the use of a non-antibiotic compound to prevent urinary tract infection in women, which was really quite groundbreaking. And when I talk about level 1 evidence, I mean evidence that you can't really argue with. So all of the biases have been dealt with. Selection bias has been dealt with, randomized element, and this is what we really needed. So this trial is something that I'm absolutely delighted to cascade. The full publication's in the BMJ if you want to look at it further. But why did we do it? Well, we did it because we've got a problem, haven't we? And the problem is we're running out of antibiotics. And the issue is the acquisition of resistance by bacteria. And bacteria have been around for a long time, a lot longer than us, and we're not going to beat them, not with antibiotics or perhaps with anything. So it's about living with the bacteria and to try and halt the acquisition of antimicrobial resistance. Just as Alto was starting, there were isolated case reports coming through from abroad of patients submitting urine samples where there was not a known antibiotic to treat it. So we're back to pre-penicillin days, and it's over to you and your immune system. And I don't mean to be overly dramatic, but that is, we're talking about modern medicine going back hundreds of years, and really the only tool that you'll have to fight off a urine infection will be your own immune system. And how did we get to this? So we got to this because of overuse of antibiotics, and not just medicine. Agriculture has got a lot to answer for. If you look at these two maps, fluoroquinolones, when I first came into urology a couple of years ago, ciprofloxacin, a fluoroquinolone antibiotic, was your get-out-of-jail card. If somebody came in with urosepsis, you gave them ciprofloxacin, and almost universally they got better. And we used it, and we used it, and we used it. And what we saw was the usage of fluoroquinolone antibiotics and the resistance to fluoroquinolone antibiotics can almost be directly mapped, even in a very mobile society, the like of which we live in. If you look at the graph on the bottom of the slide here, this is the first decade of this century, and it shows pretty much every antibiotic you can think of, which is documented in a line graph, and the degree of resistance over time. And everything, apart from perhaps nitrofurantoin, is going up. But what's going up almost exponentially is ciprofloxacin. So this go-to antibiotic that was there when I first went into urology, now 15% of the time will be useless. So this is quite an important concept to underline why we did this trial after all. This is even scarier. This is more contemporary evidence, which was published by one of my previous fellows. And it looks at hospital-acquired UTIs according to continent. So the different coloured bars are different continents. The global resistance rate is the one in royal blue at the left-hand side of the graphs as you look at them. But look at the percentages of resistance that we're encountering in all of these commonly used antibiotics that you probably prescribe all the time or you see prescribed all the time. So this is an issue, a big issue. And they knew about this, okay? So the World Economic Forum met in 2014, and I don't normally put out-of-date slides in my presentations, but I just can't get rid of this because right next to antibiotic-resistant bacteria, there's another possible global threat, which you can see there as pandemic, and that's happened. So it underlines that this has been a problem for quite some time. So in my practice, I'd used methenamine hippurate quite a lot. It's hydrolyzed to formaldehyde in the presence of acid urine. So the very sort of distal part of the kidney, this hydrolysis takes place, and formaldehyde is bactericidal. So it kills generally E. coli by breaking up cell membranes and cell proteins. The evidence was a little bit in and out in terms of we had a systematic review, so that's high-level evidence. But what it did say is that it's a collection of, you know, a little bit questionable studies in terms of their quality. What it did report is that if you look at some studies, the effect of methenamine was really quite overwhelming. And they talk about this thing called relative risk. So this relative risk here is 0.24, which means basically if you give 100 people methenamine, it'll work for 76% of them. So in essence, what that's showing is that there was some preliminary evidence before ALTER of a beneficial effect for methenamine. The systematic review had speculated that it may be ineffective in patients with neuropathic bladders or abnormalities in the renal tract. And it talked about a need for large, well-conducted RCT to clarify. So we did one. So this is the ALTER trial. This is the protocol, which has been published now for several years. It looks at women with uncomplicated urinary tract infection. And by that, I mean no structural or functional abnormality. This is the 90-odd% of patients you see coming through your door with recurrent UTIs. They don't have a urinary tract abnormality to look at. The urinary tract functions correctly, but nevertheless, they still get recurrent UTIs. And this was a straight two-arm RCT. So the patients were randomized to receive prophylactic daily antibiotics, which is the current gold standard, recommended by any guideline you look at, international, national. We'll talk about recommendations, first-line recommendations for prophylactic antibiotics, or randomized to methenamine for a 12-month period. And one of the problems we saw with prophylactic antibiotics is that they're good while you're on them. You know, they do actually keep infections at bay, as you'll see from my results. But previous literature has suggested that when the prophylactic antibiotics are withdrawn, patients relapse. So we included a 6-month follow-up phase. So it was an 18-month study protocol. They got the active drug, either methenamine or prophylactic antibiotics, for 12 months. And then for 6 months, they came off it, and we looked to see if they relapsed into their previous UTI frequency. So this is the first way that ALTER slightly differs from a lot of trials that have gone previous in what was our primary outcome. So for our primary outcome to be satisfied, patients had to go to a healthcare practitioner with symptoms suggestive of a UTI, and that healthcare practitioner had to then write a prescription for antibiotics, i.e. be sufficiently satisfied that this was a UTI, that they prescribed antibiotics to treat it. So it had nothing to do with what the lab was telling us, what bacteria were isolated 3 days later. This was a clinical UTI, and this is what the patients wanted, and we got a lot of this from this organisation. Patients were frustrated about urine testing, and you're going to hear in the next talk a little bit about the frustrations associated with UTI diagnostics. So we relied on a clinical outcome. So we looked at clinical effectiveness and cost effectiveness for the NHS of these two licensed preventative treatments. So on the one arm there was daily antibiotics, and on the other arm there was methenamine hipurate. In terms of the daily antibiotics, they were allowed to take one of a list of 3 commonly used antibiotics for prevention, which is in accordance with NICE guidelines, and that's cefalexin, nitrofurantoin, and trimethoprim. So as I said, the primary outcome was symptomatic antibiotic-treated UTI. This had nothing to do with the trial teams. I didn't treat a single UTI in ALTER. These UTIs occurred on a Friday night and went to the walk-in centre, or on a weekend went to A&E, or during the week went to the GP. We just recorded them. We did take a urine sample at the time so we could analyse the urine. And we looked over a 12-month period at the UTI rate and compared the two. But we needed to sort of set the bar somewhere, and this is where the patients came in, and we talked to them about, you know, if there were 2 treatments, what would make one better than the other? And they absolutely universally said, even if one treatment was 1 UTI a year better, I would have that. UTIs are so bad that even if I can save 1 UTI a year, or if the difference between 2 treatments is 1 UTI a year, I'll declare that better. So that stopped me sleeping for about 5 years because I thought it was such a high bar to try and get over. But as you'll see, we managed to. We looked at loads of secondary outcomes. as I said, we looked at UTIs in the 6 months follow-up period. We looked at antibiotic use, total antibiotic use, both in the treatment phase, which was 12 months, and the follow-up phase, which was 6 months. We looked at the development of antimicrobial resistance. So I had all the patients swabbing their perineums and sending it off to the lab for culture to see what was in their sort of fecal flora. It was a bit of a crude test, but I think that was a balance between acceptability, what the patients would do, and accuracy. We looked at the number of microbiologically proven UTIs, number of positive cultures. We looked at incidences of asymptomatic bacteriuria. That's the presence of bacteria in the urine without any symptoms. We looked at hospitalization. We looked at patient satisfaction. And we looked at a range of qualitative and health economic outcomes, which I'm not going to address today. I'm just going to stick with the clinical findings from the trial. So this was our cohort, and what you can see is that roughly they were split 60-40 between peri- and postmenopausal women versus premenopausal women, and that really reflects what I've been seeing in the clinic for many years. What also I think is very representative in this trial is the mean number of urinary tract infections at baseline was around 7. So these women were getting about 7 UTIs a year. Very, very few of them had ever taken methenamine, and about 1 in 4 might have had a try of prophylactic antibiotics in the past. So this is very representative cohort of what you would see in your clinic, frequent UTIs affecting kind of 2 peaks, younger women and postmenopausal women as well. The antibiotic used were mostly nitrofurantoin. A quarter of women had daily trimetoprim, and 1/5 of them, the cohort, had daily cefalexin. We always run pragmatic trials because I think that helps with recruitment. And therefore, one pragmatic element that was included in ALTA was the ability to switch between strategies if they weren't working. I wasn't going to keep a woman on 12 months of preventative therapy that didn't work, so I was going to allow changes. 18% of those patients who went on methenamine swapped over to antibiotics because of lack of effect, and only 6% of those who were on antibiotics swapped over. Now, the main reason we think for that is not the differential in their effect, but the fact that if you were in the antibiotic arm and you were on nitrofurantoin, you had another 2 antibiotics to try. So that you had 3 agents in the antibiotic arm that you could try and be retained in the same arm. Whereas if methenamine wasn't working, you were almost forced to either drop out of the trial or cross over. So that's why the crossover rate in methenamine was 3 times higher than it is in the antibiotic arm. So we did loads of analyses. The main analysis was a modified intention to treat. So that was all patients who had been in the trial for at least 6 months and they provided adequate follow-up data. They were analysed according to their original treatment allocation. Okay, that was our primary analysis. We then did a strict intention to treat, and that was just all patients, whether they'd provided the 6-month data or they hadn't. And again, they were analysed according to their allocated treatment arm. We did a per protocol. So this is patients who had 6 months of follow-up, who'd taken the study drug at least 90% of the time, and they were analysed again according to their original treatment allocation. And then I asked for a post hoc analysis. So this is not an analysis that we specified at the start of the trial. This is just something I wanted to look at, which was a really pure analysis of patients who had stuck to their original medications, been compliant with it 90% of the time, and not changed arm during the trial. So that's the 4 different analysis populations. I don't expect you to remember them because I always forget them. But what it does show is that for all analyses, we were able to come under that non-inferiority margin of 1. So however you want to look at these data, you can't help but conclude that methenamine is not inferior to antibiotics. So for instance, in the main modified intention to treat analysis, these women who'd been getting 7 UTIs a year with antibiotics went down to 0.9 UTIs a year, with methenamine to 1.4. That difference wasn't considered clinically significant by our patients, so then we could declare it as non-inferior. That was the case, and the figures were strikingly similar. If you look at the 3rd column, that shows you the difference between antibiotics and methenamine through any analysis. And with all the analyses, the figures were coming out almost the same. So whatever population or subpopulation you wanted to look at, and however you wanted to look at them, you can't fail to conclude that methenamine hippurate is not inferior to antibiotic prophylaxis. What's really important to report at this stage is the difference between clinical UTIs, which is patient with symptoms goes, gets a prescription, calls it a UTI, versus positive urine tests. So everyone who thought they had a urine test, thought they had a UTI, handed in a urine sample at the time, and the positive rate was only 52%. So that tells me that the concordance between clinicians thinking the patient's got a UTI and the lab confirming it is no better than a coin toss. A couple of secondary outcomes. We looked at antibiotic resistance, and you can see that this graph shows the proportion of patients who had any resistance in E. coli on urine sample. So at baseline, the two groups were pretty well matched. During the therapy, you can see that the antibiotic resistance was higher in those taking antibiotics. So it supported our theory that antibiotic consumption and antibiotic resistance are intimately related. And even within a 6 to 12 month trial protocol, you're seeing a difference, which then returned to normal 6 months after they'd stopped the antibiotics. So that suggested that that the daily antibiotics were more likely to breed up resistance. Now, what was really strange, and we can't quite explain it still, is that if you looked at multi-drug resistance development, that was higher in the methenamine group. So we haven't quite got the full story when it comes to antimicrobial resistance, and that wasn't the primary the primary objective of the trial. But it is interesting to note that particular pattern for the antibiotics, which you can see on the graph there. Some secondary outcomes. So we looked at women for the 6 months when they'd finished their 12-month treatment protocol, and UTI rate did not go back to anywhere near previous levels. We're talking about women coming into the trial with UTIs of 7 a year. In the 6 months after they'd finished their treatment, the incidence rate was just 1.2 in the antibiotic arm and 1.7 in the methenamine arm, so going back nowhere near. Looking at antibiotic use, well, during the treatment phase, this did not render people UTI free, it just drastically reduced their frequency. But 56% of our patients in the methenamine arm needed a course of antibiotics during the 12 months, so they needed additional. Similarly, for the antibiotic arm, 43% needed a course of antibiotics. In the follow-up phase, though, that didn't really get any. That didn't really increase very much, although the time period did decrease. I've talked about the number of microbiologically proven UTIs. In the treatment phase especially, this was just 42%. So 42% of the samples were positive. It's 52% when you take the entire trial, which includes the follow-up period. But it's really not a good advert for urine cultures, is it? In terms of satisfaction with treatment, the patients were equally satisfied between both of the treatments. They thought antibiotics were slightly more convenient, and that's probably because antibiotics are just taken once a day, whereas methenamine is twice per day. And then the methenamine pills are quite large, but no one really made a big issue about that in the trial. With regards to adverse events, they were really similar for both antibiotics and methenamine in terms of their distribution and also in terms of their severity. What I must say is that we recorded severe UTIs as a separate outcome, and there were 6 patients who had febrile UTIs, i.e. UTIs associated with a fever. They were all in the methenamine group. And out of those 6, 4 of them needed to go into hospital for overnight stays with IV antibiotics. So there was a suggestion that, if you did get a UTI on preventative treatment, then those in the methenamine group perhaps got them a little bit worse. But, we're talking about 6 UTIs out of a total of 240 that we recorded throughout the course of the trial. So it's not an enormous risk. So in conclusion, we think that this trial's demonstrated that methenamine hippurate, which is a non-antibiotic preventative treatment, is not inferior to daily low-dose antibiotics, which are the current guideline-recommended standard. We've lobbied NICE to amend or to have a look at their antimicrobial prescribing guidelines, and they've agreed to do an exceptional review, and that's in process progress. I'm hoping that then we're going to get a recommendation for methenamine, and that will hopefully help in terms of increasing the uptake and giving the patients this kind of non-antibiotic option. And I'm hoping that it will be considered as a first-line option when conservative measures have failed, especially in women with a history of recurrent episodes and normal urinary tracts. So this is just a summary of the trial in terms of the infographic, and you can see the various different analyses. They all come in under our pre-specified inferiority margin. The other guideline body that's currently looking at this is the European Association of Urology, so I'm hopeful that in the not too distant future I'll have national from NICE and international from the European Association recommendation for methenamine, and then we can sort of think about further studies to kind of refine particularly which kind of patients methenamine works best for, because as you can see from the trial results, it's not perfect. There are still a proportion of patients who don't respond to it, but it'd be interesting to know why, and things like urinary pH is something that we're certainly going to look at, and also the types of infecting bacteria. We think methenamine might be better with E. coli, which of course is the majority. So I'm happy to take any questions you have about that trial. I hope that's been an overview that's easy to follow, but it was quite a complicated trial. So any questions?
We get a microphone, please.
Hello, Chris. My name is Amar Manandar. I'm urologist in Queen Elizabeth Hospital here, and of course I see lots of patients with recurrent UTI, and this breakthrough with the outer trial is a nice thing to hear, and this has been implemented, and you said that NICE is looking at it, isn't it? So I have lots of problem with prescribing methylamine hippurate. You are just nodding that you do have the same thing.
I don't. I'm lucky in our region, but the geographical variation is, I don't want to be dramatic, but it's really not on. You know, the fact that if you live in Newcastle, you can easily get methenamine prescribed by your GP.
Can we send everybody to live in Newcastle?
Well, that's one option. And yet in other parts of the country, it's classed as a red drug.
Yes.
We're not quite sure why it's classed as a red drug.
About,
The safety profile throughout the trial was as good as antibiotics. So I'm hoping that this will all change overnight with guideline recommendation. The minute NICE rubber stamp this, then all of those problems disappear overnight. So, you know, we could have started a load of work lobbying, but actually the best people to get on side for this are NICE. They agreed to look at their guideline exceptionally based on this evidence that came out. So I'm hoping it will change recommendation.
A couple of more questions. So what I do is I have persuaded our pharmacy in the hospital to bring it for us.
Yeah.
And then I have to prescribe every time when the patient calls me or email me, oh, I'm run out of methylamine, can you prescribe? And then I prescribe and they come and collect it, or I post them. That's how I work, and it's very, very difficult. Sometimes patients are not able to contact me in exact time when they finish hippurate. And some people do get prescription or buy them online, and they're asking me, oh, it's very expensive, can I take instead of 2 times a day, 1 a day? What is your opinion on that?
I mean, I just go back to the evidence, and the evidence is irrefutable that taking it twice a day is as effective as daily antibiotics. What I didn't do in the study is study a once-a-day preparation. I do have a handful of patients who take it once a day, and they seem to do all right, but that's anecdotal. You know, I've just gone from level 1 evidence to about level 5 in half a sentence. So I wouldn't recommend it based on evidence, but based on anecdote and experience, I do have some patients who do well on just once a day.
And we do have lots of patients, as you said, they think they have UTI, but actually they don't. And like a toss of coin, you said, not better than that.
No,
So-
I don't think a negative urine test means you don't have a UTI. I think it means the
absolutely.
test has failed. These women, they've had 7 a year. You know, they know what a UTI is. Believe you me. You know, you look at other things. I get these symptoms. They're like a UTI. I take antibiotics. My symptoms go away quickly. Well, what else is it? You know, I get things like a fever. You know, I think this is a problem with the test. It's not a problem with us diagnosing other lower urinary tract symptoms
My
as an
question
infection.
was whether these patients are like bladder pain symptoms patient. They do get cystitis-like symptoms. It flares up and go normal after 4 or 5 days. When they take antibiotics, they think that antibiotics has done the job, but actually not. It flares up 4 or 5 days. It's self-limiting in a mild cases. I mean, bladder
Yeah, I
pain
mean,
symptoms.
what I would say is that if you look at some of the studies that have looked at antibiotics versus anti-inflammatories for UTI, they show that, you know, over 2/3 of patients who treat UTI symptomatically get better without antibiotics. Doesn't mean it wasn't a UTI. You have an immune system, so therefore that's probably kicked in and cleared the UTI. You know, antibiotics are not the only thing that will eradicate urinary tract infection, but I don't personally. I think this kind of bladder pain thing is one of the most I mean, you're going to get me on my soapbox in a minute, but I really think that bladder pain syndrome is the most overdiagnosed condition. You know, interstitial cystitis, it's what you go to when you can't, you know, when these tests are letting you down, in my opinion. But yeah, I mean, I don't want to steal Gail's
But
thunder,
yeah,
because
but,
she's going to talk about it in a second.
women do suffer from bladder pain syndrome, isn't it?
So I've got a lady at the back, this lady down here, do you still want to ask the question?
No, that's
No,
fine.
okay, fine. Lady at the far back, with her hand up first, that lady there, with the, in the middle, glasses, is the first one up. I think, apologies.
Thanks ever so much, Chris. That was a brilliant presentation, as always. Would you recommend 12 months of Hiprex then? Because when I'm prescribing it, or when I'm asking GPs to prescribe it, there's a bit of obviously pushback. But is it 3, 6, 12? You know, it's all a bit like, ooh.
It's definitely 6.
Definitely 6.
Preferably 12.
Oh, right.
Yeah, that's, and you know, what you've got now is you can say, well, look, the evidence points
Absolutely.
to 12.
Perfect, thank you.
Lady just in front, and then, oh, sorry, over there. Sorry.
I can't hear. Okay. Hi, my name is Alina. I'm a physio, and my question is if you can describe in simple words what this medication does.
So this medication, because its active component is formaldehyde, it breaks the cell walls of bacteria, so kills E. coli basically. But it's a great question, because actually a lot of people in my lab are now thinking that it may not be the formaldehyde that's the active thing. So we've got these ice cubes of patients' urine from Malta who took methenamine, and they're all looking at different levels of lots of different compounds in the urine, and the current thinking from the lab is that the hippurate salt is really important as well, because that turns to hippuric acid, and acidic environment, E. coli don't like that at all. So I think the textbook answer is, it's the formaldehyde, which is bactericidal, which, you know, causes the E. coli to die. But I think there's more to it. So, you know, we might have something to speak about this time next year, perhaps.
Hi, Chris. Thank you very much. I don't really know how to word this. It's around the MSUs and extended cultures, and whether there's a study to encourage our country to change the way we do check urine with all these 52% of negative MSUs that we get back.
Probably goes with the next.
Yeah, I would ask that in about 25 minutes' time, but yes. I mean, the only thing I would say about extended cultures is that, you know, we know that the bladder has bacteria in it, and the extended cultures tend to, you know, it tends to draw out these bacteria. Doesn't necessarily mean they're pathogenic. So I have a little bit of a problem with extended cultures.
My question was just, is methenamine contraindicated with BCG?
I don't think it is. I've never come across that, though. The big contraindication for methenamine is gout.
Yeah.
what intravenous BCG therapy?
Yeah, so we've got a patient at the moment, she's got E. coli recurrent infections, lab proven every single time. It's delaying a treatment every single time because antibiotics are contraindicated with BCG.
Yeah, I don't
is
think
delaying
methenamine is,
treatment.
but I would need to check that.
Okay,
I
thank
would
you.
need to check that.
Any other questions? Down here.
Hi, Chris. Just a question on the recruitment. So you mentioned Bladder Health are really supportive. So the recruitment for your study, how were they recruited?
It was the planning that they were really important. So we had someone from Bladder Health UK who joined very early on. I mean, I'm about to ask Susanna for another one because we're planning another trial shortly. And they just so it was them that said, don't rely on urine tests. They're all, this came from the patients. And then when we got a patient focus group together, we looked at, where they would set the bar in terms of declaring one treatment. And I didn't dream in 100 years that they'd say just one UTI. And, I was, throughout the entire trial, I was worried that this bar was far too high. Methenamine was never going to make it. And, but yeah, no, they were just great. And they're just, in terms of just so many aspects, helping us write a good lay summary, with the best will in the world, when you're a medic and you try to write a lay summary, 3 or 4 medical terms creep in, and you can't, and it just, they can't understand that. And they're just really, really good. At the start of the trial, throughout the trial, we had somebody who sat on our trial steering committee who represented sort of the patient's perspective on it, and then dissemination. So we've already had a couple of pieces in the newsletter to disseminate the results of this trial. So basically every single aspect, it was just necessary and brilliant.
Any other questions?
Yeah, I've got another one here.
Can I ask one actually?
Yeah.
Is there a maximum duration for taking Hiprex?
So this is something that I used to talk to James Maloney a lot about because he was a big fan of methenamine hippurate, and the safety data is quite supportive in terms of the concentrations of methenamine. But of course the worry is formaldehyde. We know formaldehyde is classed as a carcinogen. But in the concentrations that's coming into the bladder from methenamine, we don't think that would be an issue. And there is a European safety report to support that view. I do have a handful of patients, no more than a handful of patients who just can't come off it. They come off it, they relapse into infections, they don't want to take antibiotics, so they do take methenamine in the longer term. So obviously we're keeping an eye on those patients, but there's nothing to indicate it's not safe. Do we have proven safety data over an extended period, like decade or longer? No, we don't.
Okay, thank you.
Thank you so much for your presentation. I was wondering, in the postmenopausal women that were included in the trial, were they on vaginal estrogen, or did you exclude them?
So it's when we do trials, they're always pragmatic. They could take estrogen, cranberry. We recorded it all, and the we called it supplementary treatments. They were well balanced between the two arms. So I did, just like we would do in practice. You wouldn't just concentrate on one single thing. But yes, no, I think it was about. In the postmenopausal arm, I think it was about 20% who took. I'd have to look at that for the exact figure, but I think it was about 20%.
Any more? Okay, I have one question from a layperson's point of view.
Yeah.
The red flagging of the drug. I know here, if you want it here at this spot,
Yes.
you can't get it. You go a mile down the road, Warwickshire will prescribe it. What's actually the route? What's the reason for them not wanting to?
I think it's the safety issue that we were just talking about there. It's the formaldehyde. I think that's probably the thing. And the other thing is that it doesn't enjoy guideline recommendations. So in the first antimicrobial prescribing guideline that NICE produced, they said they couldn't make a recommendation because the evidence was patchy. But then our trial came out, and they did the right thing, which was agreed to look at it straight away. But that will finish it. And I can't see they can argue with this. I mean, as well as Alta, there is another trial that's come out from the States which shows exactly the same results. So I'm hoping we're both not wrong.